I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Any public comment? Hearing none,
Just look too much glare.
I'll ask them for the approval of the consent agenda.
Also move.
We're going too fast for you, Jen.
Kind of need somebody to sign checks in August. Well, Charlie and Cheryl might, I hope.
We would. We thank you all.
There's August, I'll send that one around.
I can only
Moved and seconded. All those in favor signify by saying aye.
Aye.
Cheryl, what do you think? Go for it? All right, Ron.
Okay, so the first slide is about the financial impact of COVID. And whether, I've said it before, I spend quite a significant amount of time listening to webinars about where to get money, how to spend money, how to prove how I spend money, how to record the spending of the money, how to record the income. Lots of discussion, lots of advice, lots of big brains working on it. So because there are so many sources, I rely predominantly on Quickly. So we had a good discussion this month about recognizing a bunch of the CARES money. So finally taking some of that millions of dollars and applying it to our losses. Because we're feeling very comfortable that we're going to keep that money, that it's pretty easy to prove the losses, and that we should go ahead and start recognizing some of that as revenue.
And you'll go over what we did in May.
Oh yeah, absolutely. Another thing that we did was to go backwards a little bit and put some of those in March and April, so we didn't record it all in the same month. We applied it to the months where those losses occurred. So it makes May look less of a really weird standout month, although all of the months right now look really, really weird. The money we added in May was these two grants, which total $183,000. And then in June, we've got these two grants, which total $59,000. And at this time, I'm actually only working on a couple of things. One of them is the rural hospital relief. And then there's another 75 that might come to wellness. And I'm not really aware of any other money that we might be expecting right now.
So that relief, rural hospital relief, $50 million has been defined by, it's come to the state legislature, directed Business Oregon to disperse it. And some of the rules are, we're struggling to understand their rules. So there's a lot of things.
Webinar Monday.
Trying to figure out what does that mean.
Charlie, how many hospitals will be in that pool?
There's 31
31.
that are eligible to participate in the 50 million, provided the provisos that the state legislature match with what Business Oregon requirements are. At this time, we don't think any of the hospitals will qualify. So we're dealing with uncertainty.
Shows a lot. The largest one is the WAFA SBA loan assistance grant. Could you explain what that means?
That means that at this point, I feel more positive than not that that will turn from a loan into a grant.
That's not payroll protection.
Yeah, that's payroll protection.
Oh, that is the payroll
Yep.
protection.
It is. And based on, they have not allowed us to start applying for what they call the repayment or the relief, the grant. We can't apply for that yet, but it's looking more and more like the criteria for forgiving it, we're gonna be well inside of those parameters and we should. But for now, we're gonna keep treating it as a loan. Okay. I think that's it for
Needless to say, it's hard to figure out, and it keeps changing.
And it probably will. I mean, it'll probably keep changing well into when we get our audit done and our cost report done and how we treat things and what we have and what we don't have.
But we kept people on the payroll, we kept.
Yeah.
So
Oh,
that's
yes.
the main criteria
Yes,
in general,
yes,
was the payroll protection. It didn't drop your payroll.
That's correct.
did not.
And we hope that we won't have to in the future. But tomorrow, it's hard to predict.
Okay, so in May, we had a total of 306 patients in the hospital. We had 31 hospital patients, we had 244 ED patients. Our May patient counts, these up here, are 86% of normal for us, which is interestingly enough a pretty common theme across the hospitals in Oregon. I thought maybe we were doing better than other people, but it sounds like most people are in the 80s in May, 85% into 90% in June, which is what we're seeing. A lot of bigger slides in our ancillary services. Lab was still quite good. They're at 93%, probably because of all the COVID testing, among other things. Radiology is at 83% of normal, rehab's at 90% of normal. The health clinics are struggling the most. The lay clinic is at 75% and Alturas is at 40%. So.
Is there a new doctor in place there now?
Cheers.
Now, Alturas doesn't have any cases, do they?
We have not had any test positive yet, that is correct.
Gross charges for May bounced back up to $3.1 million from our low in April of almost $1 million, which is 90% of average, following our case counts. Our collections and AR, following our worst month of the year, where our collections were the worst month of the year at $1.4 million. In June, we have collected $2.164 million, so rising again with that better billing in May. Our days in AR has dropped to 71, which we kind of expected since we.
Come on in,
Go
Don.
off my pay. Sorry I'm late.
Alright, and our days cash on hand is right at 89. Our goal is 90, so
Good. Must be taking out.
I'm only including the grant money, yeah. So, all things aside, this is a fairly real number. What I think I can count on is money that we will keep, not money that we're gonna have to give back, or earn back, or
That's
anything
right.
else.
For me, confidence need to be.
Right.
Yeah.
Yes.
Right.
Yes. Of course, the other covenant is very positive again with the increase in cash also. Okay, so this is our actual net revenue, 2.6 million for May, this is budget, this is a year ago May, so really not too bad when you consider all things. Because we reported that other revenue, Don, because we talked with Whitley and all the powers that be, and we've started recognizing some of that revenue. The CARES money and some of the grants, none of the loans, not the PPP loan, none of that.
But this is in Whipley's opinion that that's
Yes.
gonna be really income.
Yes, yes, according to their formula in our discussions, a lot of webinars on the subject, but we actually did have a specific discussion with Ripley. It's not to say that they're not gonna change their mind, because we're now in audit, things might change, but I mean, really, it's a pretty good bet that we're gonna keep the CARES money. It covers the losses, essentially they're saying, cover what it cost you, where, be where you should have been.
What is the measuring period of payroll protection fund?
Well, it's been changing, I mean, it's right in the midst of changing, so they've expanded it from like 8 to 24 weeks, I think.
24 weeks after the receipt of the money.
So then that's,
What would that put us?
that we would be able to keep it all.
No, but when this 24 weeks.
Oh,
Toward the end.
I don't know, we can do the math and tell you, specifically.
It's about 8 months.
But you can also count other things too, besides payroll, so.
Right, the payroll has to be 75% of it.
It brings us to about the end of the year.
But our payroll
Not
is,
quite,
yeah,
because it started in March.
so, 24 weeks is how many months? Almost half a year, right?
Yeah.
So our wages, year to date are close to 16 million, so, we have plenty of wages to cover the $5 million we get,
I think it's highly likely
We would hope so.
Yeah.
But until we get the forgiveness from the bank, we're not gonna count it.
No, we're not.
We're being much more, we're being as conservative as we should be.
Yes. Yes. All right, so this is our year-to-date, actual then. This is actual revenue budgeted, so we're 2.8 million behind where we budgeted to be. Wages are $1 million behind. That has more to do with, doctors not starting as soon as we had planned. Benefits were higher. Materials and services are $1.4 million above budget. I did look at that a little bit deeper, and when this all started at the end of February, we were 10% over budget in our materials and services, and most of that had to do with contract labor. So now we're 16% over budget in materials and services. That number has doubled since February, so in March, April, May, that caused another 700,000, and a lot of that is COVID related. So, which brings, falls to our loss and is made up by this non-operating income that we've been able to recognize. So, anyway, so our year-to-date number now is $2.2 million, and last year was 352, so bringing us where we should have been. And June is turning out to be a very busy month. Very busy.
I heard our operating room is running pretty hot and heavy.
Operating room is busy, seems like the OB is busy, the hospital has been darn near completely full a few times.
I was truly surprised when I was on a board meeting call today. Virtually all the hospitals are very, very busy. The public is feeling confident that they can go to the hospital again. The CEO at Salem Hospital said they have 41 patients in their ICU. A third of those were patients that had held back care during the principal starting of the COVID crisis, and they had conditions that now put them in emergency in the hospital and put them in the ICU because they withheld getting care. So hopefully that isn't happening here. It appears that our kinds of admissions that we've had, our deliveries had nothing to do with the virus, as an example. That was rodeo. The other admissions that we've had have been related to other kinds of conditions. So hopefully we're not having them. And we would have seen it hopefully by now, people that held back from getting here. That's really the key part. We want people to feel safe to come to the hospital to get care.
Okay. Lakeview Gardens had 634 patient days, which is about 21 people essentially. And assisted living was at 341 patient days, which is about 11 people. Year over year, an increase of 1,300 days.
And keep in mind, we have not been able to admit people to, but unless we know who they are and we know a lot about them, because of fear of bringing COVID into long-term care. They're our most vulnerable portion of the.
So are we gonna have a quarantine over here, then, or, how does someone get in?
Right now, it's very restricted. If we have somebody that would like to come, we'll track where they've been, how their care has been, why they're coming. If they've been home, they've been self-isolating, then we can let them in. We're just not encouraging people from out of the community to come in. That could potentially put our most vulnerable at the greatest risk. Was a recent statistic that at that time there was 120,000 deaths in the United States. 50,000 of those were all from long-term care nursing home facilities. 50,000 in the country. So clearly, it is impacting people that are absolutely most vulnerable. So we want to keep our Lincoln County population as safe as possible. So we haven't seen variation in population.
Okay, so the revenue's been pretty static, not surprisingly, 225,000 for the month. And in assisted living, it's 3,000 for the month. And then for the month of May, that revenue was 249. Contract labor, broken record. The loss for the month was 124, and so now this year and last year are awfully close comparatively.
As an example of what's happening in long-term care, since, well, I think it's been 6 weeks, we've had 3 state inspections of our long-term care. They have not found any problems with quality, with our infection, anything. But it seems like every 2 weeks they're gonna show up.
Are we inspecting the inspectors before they come in?
Yeah. We're not being isolated. I think the state is investigating all of the long-term care facilities because that's the most vulnerable population. I want to make sure that everyone is doing everything they can to keep that population safe. The last thing we ever need is a problem.
Comments? Okay. Looking like with the COVID-19 update, I'm taking over. It was great though while I had that.
Oh, geez.
Well, I gotta slow things down, the guys can't go home too early tonight.
I can talk slower too. So a couple things to keep in mind. Today, unfortunately, is the salary state of affairs. It has the highest number of cases reported in the state of Oregon since all this began, 375 cases.
Who's that?
Pardon me?
Oh,
State of Oregon,
State of Oregon.
375 cases. Brings our total number of cases to 9,294 as of noon today. In Lakeland County, we now have 19 cases that we've tested positive out of about 400 tests as of last Friday, when I looked at our testing to positive ratio, we were matching that of other large cities. So our testing and positive case number were in line. It's hard to understand how other counties continue to have no cases. We have now the Abbott testing, we had the Abbott testing capability. There were 3 hospitals that got this. Us, a hospital in Gold Beach, and a hospital in Pembroke. But then the state was very restrictive in the number of testing samples that they sent us. We now have several hundred. We still only test if with a physician's order. We're not just patients, community members coming in saying, I want to be tested because I think I might be exposed to something to that.
Charlie, with this Abbott testing from when you take this test to get results, about the time turn around to running this.
About 4 hours. The challenge with the Abbott testing is that it's showing to be about 80% accurate. 80%, the hard part about that is the number of false negatives. So you're not sure what you have. So we often will test with an Abbott to see, and then we'll send out to our outside lab. There's some other testing capabilities, but it's, it creates not as much confidence as we had hoped. This is not just us. This
What's
is,
the turnaround on the other tests?
it's about 2 to 4 days. It varies. Some of it we get it quicker. And we send our tests to Quest. Quest is getting, as is LabCorp and Interpath, the main lab testing capability facilities in the state. It's getting faster and faster. We're required to have a response back in 4 days. We're trying to be able to get that. It's difficult on Friday to get it back by Monday or Tuesday. There's some variation in that. A lot of people have said, well, who is, are all these people related? And are we doing contact tracing? The answer is, we are doing contact tracing. We are finding that, what that means is, as soon as a person is tested positive, public health staff begin the process of calling not only that person, but anyone they may have had contact with. We use a state software program called Orpheus that all public health departments in the state use to track the patient. If we were to get overwhelmed, as they have in Lincoln or Union County, the state has offered to help with a lot of the telephone calls we get from out of the area. We have both English and Spanish speakers. In some areas, the Spanish-speaking portion has been difficult because people have had other dialects or other parts of the Central American countries where some of the workers have come from. So we have not had that problem. We believe about 3 what we're calling pods. I'm not sure if that's our internal language or the state uses that language. Sort of groupings of people that seem to be, have been to the same place, may have worked at a similar place, may have been to a gathering, something to that effect. But there seems to be some correlation. They're not all independent of themselves. They're not all from one big gathering. That's what happened in Union County, where it was a church. They believe was the principal location. Sometimes, for example, one of our employers has several, it's reported by the Oregon Health Authority that 5 employees are positive. And so are we going to close down that employer? Well, no. Largely because all the people that have been tested positive are self-isolating and are staying home. And the rest of the organization is being followed, but it's not being shut down. So precautions are being taken in all cases.
Do we have any individuals hospitalized because of COVID?
We have enough. We've had several cases where physicians have treated someone as presumptive because they seem to have conditions, but they are, so they'll treat them as though they are, and then it takes time to test and come back to valid. What they have decided in Union County is the hospital there decided not to tell the public at all if anyone was admitted or not admitted. It's a small community, people can make all sorts of assumptions. They're taking care of patients and treating them properly. So each community has an option of how do they define for their community. I can assure you that we often get calls asking, well, was it this person? Was it that person? Administrator from Salem Hospital said, according to the Oregon Health Authority, they had multiple number of employees that tested positive. But because of FMLA, the hospital didn't even know who those people were. It took a long time for public health to announce to them or to tell them who those people were so they could assist in contact tracing. Because the hospital didn't know who those people were, as you would imagine. So it isn't an easy answer to say, we're going to tell our public who's got it. We're not going to tell them. Because that's just not the right thing to do.
Still 14 days for the self.
Yes. So what the reporting is, if a person tests positive, they are to self-isolate for 14 days. At the end of 14 days, if they don't need to be hospitalized, they are then no longer needing to be isolated. And after 60 days of no further flare-up or condition, they are considered recovered. Those are the criteria for how that's defined. It seems a little odd, but that's how it's done. Okay. We continue to monitor everyone, anyone that has tested positive. We continue to do contact tracing, follow up with them. Some people are reluctant to say something. In other areas where there's people reporting in Lincoln City where people have no symptoms, test positive, they have a hard time understanding why they can't go back to work. They feel fine, test positive, why shouldn't I be allowed to go back to work? So it's difficult. And most everyone needs to probably know that today the jobs report came back. A lot of people went back to work. So, questions otherwise that I can answer about COVID preparations? We still have ample amount of PPE. So that's the personal protective equipment. We have lots of proper N95s. We have lots of masks and other equipment.
What's the status of the 2 ventilators?
They actually arrived this week. And I was absolutely surprised. We were told they wouldn't be here until the end of August, September. But apparently they found the capability of delivery and arrived. Remember, one of the things that was a factor in making the decisions to purchase them was not only to be prepared for this, but what we had been experiencing prior to the COVID outbreak is more and more times we are unable to transfer our patients. Other hospitals have been too busy. They can't take our patients. Or because of weather, we've been unable to get them shipped out. And the doctors have said, we think we need to use this equipment for some of our more sick patients. And we have greater capabilities with our respiratory therapy service. So we don't think this will be for naught.
Is there some training that comes along with this new equipment?
Respiratory therapists are very, very familiar with that. So that, they don't need to learn. We may do some orientation to them, but nothing useless in other hospitals. further certification. Other questions about COVID I can answer?
Okay, hearing none. Ambulance service update. Well,
It is a slow slog. We have provided the Lakeview Disaster Unit with a lease document to lease their equipment. They have had that document since the 15th. They're still cogitating on it. It appears that they will be okay with that. We are in the process, once we take on the responsibility of leasing that equipment. There's some question about exactly what the cost will be for that. But for us to buy the insurance on that equipment, we need to have an assessed value so that we could have replacement value insurance. So we're in the process of getting a market value. That'll be helpful so that at the end of this lease, because the lease will be for a year, we will be able to either purchase it from the disaster unit or exercise our option to purchase equipment elsewhere. So we're working on gathering that. We had a candidate for the EMS director position, offered the position, and the candidate withdrew his name from the process and felt that it was too much to strain on his family. So glad that at least we have that issue resolved now, not in 3 months. That would have been a little more difficult. It's not uncommon when we look at people, bringing people in from other parts of the country, being in remote places, not as easy as all of us think it is for others. And so we continue our search. I had an interview today with another person who said, I really like it, but I can't done. So we'll continue that process. Our application is in at the state. We're still filling out forms and trying to get that. So I don't know if the state will be down to do the inspection.
Do we have a pool of other options?
We have our applications, we have our advertisements out. We have agencies looking for us. We don't have a continuing pool. The pool that we thought there was going to be a lot of because of the shutdown of several services when there wasn't transportation, they've been hired now. So we're still working.
Are we still engaging with our consultant?
We are. And what he has said is, if push comes to shove, he would act as a more engaged director. So if it happened. So while that wouldn't be our optimum import for us, we will deliver the service.
so he would be interim until we found someone for.
He's actively looking to help us so that that interim possibility would be limited in its duration.
It'll be a good resource.
Right. So I wish I could give you more positive news on exactly where we stand, but these things.
And the disaster unit is fine continuing until we are.
As far as I can tell, they have not gone uncalled. They continue to respond. They are still ultimately responsible. The process again is disaster unit sent to the commissioners. The county commissioners reviewed it at their meeting. They agreed to the transfer from the Lakeview disaster unit to the Lake Health District. That information was sent to the state. It's in the state's hands. When the state says, we're ready to take this on, it becomes our responsibility. Until that time, it is still the responsibility of the Lakeview disaster unit. And that has not changed.
Do we have an anticipated date of the state responding?
June 1st.
June 1st.
What year?
So the answer, I know that sounds silly, but remember, we sent the application and the information in April, latter part of April, first part of May, anticipating June 1st would be the transfer date. That's what the disaster unit said, they needed to make that change by. Normally, the state comes out and does a physical inspection. They still have been willing to accept photographs. We haven't changed on that. We're providing them bit by bit all the information they need. I think at any time the shoe could drop and they say, okay, we approve you, go. And I worry that that's tomorrow. So I can't answer when they'll do that. I hope they will pick a rational date and say, how about August 1st? Or something that gives us a little bit of time. I'm hoping that happens, but I can't predict it. And I'm also hoping that the disaster unit doesn't come back and say, we just can't do it anymore. That you did, no matter what. So both instances keep me up at night. You know what their financials are, but we won't ask. Just saying. Other questions about our ambulance service like this? Moving on to the next.
No, okay, yeah, medical staff.
So Dr. Gallagher's not here, but I can tell you that the medical staff has been absolutely overwhelmed with meetings to work on COVID-19, as you can imagine. Discussing care plans, discussing what they would do, structure, just all sorts of things. We're as prepared as we could be. So we have not worked on a lot of applications. So we will be having that this month. So that at the next board meeting, we'll have more active information in terms of applications to review at this time of year.
Notice in Facebook, you know, like dermatologists and your other folks coming on, which is real positive.
That is my next part.
Oh, I stole your.
Can I go with my report?
You got the CEO report.
I'm working on trying.
Beat the record?
No, no.
Can't possibly talk faster, Charlie.
Okay, a couple things that are going on outside of COVID-19, because there are many, many other things. Yeah. July 20th, in 18 days, we will go live with service. That is, once again, the Hydra is raising its head and everyone's anxious. Lots of training going on, lots of process. Anxiety is getting great, but we are confident that we will do well in that process. We'll ask the public to possibly consider during that week to maybe consider coming to the hospital the week after, so that we're not overwhelmed in the clinics or other places, so that as we are transitioning, staff is learning their software and applying it properly. Practicing, but it takes a little time to get used to a new system. So it's an exciting time and nerve-wracking at the same time. We have already started with our multi-view. You're seeing the benefit of that through some of the financial reporting. It's not perfect yet, but it's getting a whole lot better.
It is, we need Cerner to start in order for multi-view to be completely as useful as it can. It's not getting anything from Cerner yet, because we haven't started.
And we are also using the software program Chronos for our payroll and personnel systems. We'll go live with payroll in August, and then we will go live with personnel in October. It's a staged process because there's so much information that goes on. We have to change all of our time clocks. And we've got, there's just a multitude of different things that will change with this new software that we did, that is different from our CPA system. So that's kind of an exciting time. We are working on a remodel in our long-term care portion. When you go south, or excuse me, go east, go west, and get my directions right. The end of the hall here, sort of catty corner to the Street Conference Room, there's a valley in the roof line. And while we were getting prepared for converting all those rooms ready for COVID-19 patients, we found that there was some damage from water that was caused by leaks in the roof that had occurred over an extended time period. So they're beginning work on that. We had to engage an outside firm to come in and help mitigate and be prepared for the asbestos removal. So that'll be starting in the next couple of weeks. It's going to cost us about between $12,000 and $18,000 just for repair. Unfortunate, but we have to take care of it. So we'll be doing that. And Don, to your point, there are several new physicians that we brought on. Dr. Young is our OBGYN. She started this, just finished 2 weeks. And that's very, very exciting to have someone of her skill and capabilities. She's already been fairly busy, so that's great. Dr. Wisco, Oliver Wisco is a dermatologist. He'll be coming once a month, and his goal is to have either him or his physician assistants here 2 days a month. And he would come a third day to enable to do surgical procedures to remove cancer cells. So he's tried this. I think I've talked about this in the past. He's done this so far for at least a year in Burns. Very quickly they became very, very busy. So we're excited to add that service to our clinic. Dr. Galen Keneally started in Alturas, and that's moving along. It's going to take some time to build up that service. Our strategic planning meeting is going to be July 29th. It's 3 weeks from now. And Paul McGinnis will be our outside, he's now working for us, consultant to help us with that. He's already begun the process by doing some discussions and questioning managers. We'll be able to provide you with that kind of information. He's going to do some board education and then some also others. Use some other tools to help you as a board work better and focus on some of the issues that we have to do.
What's his background?
Paul has degrees in healthcare and health policy. He's been with the Office of Rural Health through OHSU for I think at least 10 years, maybe 15. And then most recently worked for GOBI, Greater Oregon Behavioral Health, and his contract with ECCO. He was very instrumental in developing a lot of the systems for working on the quality metrics as well as other components of clinic services. So having him support us is going to be really helpful. He's got a couple of things that he's working on right now. Aside from working with the board, we'll be working with Carly Remstead as she takes on the role as the clinic's director, helping her get brought up to speed. Paul, as an example, was very, very helpful in Dr. Graham getting his Rural Health Clinic certification. So he's very expert. He's probably one of the leading experts in the state in rural health clinics. So we're very fortunate to have him. some of the crazy things that have happened. The state, you may recall, every year with our contract with ECCO, we get about 18 months after the end of the year, we are scored on how well we did at meeting the metrics. Those metrics are multiple things that the Oregon Health Authority comes up with, like checking how many people have not smoked, how many women are pregnant, how many are how well we're managing the diabetic population, a variety of different things, and our CHIP program is active. So normally we get a bonus in about September, and you've heard Cheryl talk about how we try to figure out money that was earned the year before, but we don't find out, we don't actually get the money until September. We don't know how to predict it. Well, they took the unpredictability part out of it, and they gave it to us. So they gave it to us in the month of May. I think Cheryl showed you, we got 28,000 in one batch and $22,000. They said, you can't stay on top of your metrics, so we're just gonna give you the money. And they did it throughout the entire state. So even though we're responsible to follow on those metrics, we won't actually be at risk to get more than that. So they just split it up and gave it to me. Not exactly what we were hoping for. At that time, the decision was made because the fear was we would not get federal assistance and hospitals would be really short of cash. We just finished our inventory, and it's interesting, we had 1,103 items in our inventory, about $174,000. The accuracy rate, we measured on how accurate was our count and how accurate was the download. We had an error rate of 2.3% count. We were 99.6% accurate value. I'd say we're doing a pretty good job. Quentin and his team did a really good job of keeping track of every, not every paperclip, but close. Which is a really good thing for you to know that when Cheryl reflects financially what we're doing, our inventory is accurate. So that's pretty exciting. Other than that, it's been kind of slow. Any questions that I could answer about other things that we're...
Charlie, I noticed that the clinic is going to be closed for 3 days in July.
It was on Facebook.
Walk-in clinic, we don't have providers to for that.
2 consecutive days.
Yes.
Provider training.
What can we do to keep that place open?
So one of the reasons why we're doing it is we have to get our doctors all trained on certain doctors and our midwives. They've got to learn how to use it. So for those people that need walk-in services, they may be going to emergency. It's really hard for us to get somebody from out of town to come and cover. So we're trying as best as we can to both mitigate the needs of the community, but also make sure our providers know how to use this computer system. If that doesn't happen,
So this is a one-time deal because of the training and all of it. Okay.
this is not going to go on for long. But we've got to have time to get them the capability of learning the system. And
It's best if they learn right before go on, not because they're just,
Because they start meeting with patients and they can't look things up.
Right.
Find records.
Exactly.
Chaos.
so better to have them so they're the last people to get really well trained.
so hopefully our staff will have lots and lots of training. And they're comfortable enough with the system that as the practitioners are using it, if they stumble a little bit, we've got people there to help them. But we need them. It's a steep learning curve. We need to give them the chance to learn it as best they can and then use it.
How long will the Cerner people be here to this is?
Well, it's a good question. Originally, they were gonna have an army, and they were gonna stay for as long as it took. Now, because of COVID, they are gonna do a lot of that remotely. So they won't physically be here, there'll be many people here. This planning took place 3 months ago, 4 months ago. And so it was a big concern for us. It's gonna impact the cost because we won't have as many people here. But there'll be a lot, they've already, I think it was reported they've done about a dozen other facilities on this remote. They'll have some people here, but predominantly they'll be remote.
There will be quite a few people here.
There still will be a lot.
And we've trained extra people, and they're not here because of COVID, I mean, that has a lot to do with it. So they're changing their model because in response to COVID. But we've trained people extra well, so that we can support our doctors and our staff more than what was the original plan.
It's modifying itself as it moves. And you're right, I don't know enough about it. Stephen is out preparing for the onslaught, so.
They also evaluated each of the departments, our Cerner counterparts, evaluated how well each of the areas was doing and how comfortable they were with our readiness for conversion when they decided who needed to come on site versus who didn't. So it wasn't just like a random selection, oh, well, only half the people are coming. They really worked well with us to make sure that we felt prepared and that we were comfortable with those people supporting us remotely.
So, but they've also assured us that team will be with one main team until our days in accounts receivable are about where they are before we provide. So depending on how long that takes, that could be either a relatively short time period or even longer.
And then also to support the doctors, we did bring in our regular locums, Dr. Smith and Dr. Buell are gonna be here over the next several weeks to kind of take that brunt off of our providers being in the ER. It allows them that additional time to train and be in the clinic, so they get more hands-on with that, and then it will also allow our other providers to get some of that training too while they're here, so.
So we're trying to be as thoughtful as we can. The team has spent a lot of time thinking about this, trying to make it work. So I think we're pretty confident that it will go, hopefully it will go really well. No, it'll go.
Our orthopedic surgeons already know about the surgery, don't they?
Well, Dr. McKillicuddy is now the only resident orthopedic surgeon, Dr. Lincoln is and he has a fair amount of experience with other systems. He will still need to learn the flavor of Cerner that we have. So there'll be some differences. Dr. Chang, same thing. All the physicians have to learn. But it's what, you have to learn the nuances. Every system has little variations. Other question?
Any other questions?
On the strategic planning, and Paul McGinnis, is he's going to have a pre-meeting with us or to go forward on the 29th?
You might have some material in advance, we're still talking about that. Maybe some questionnaires. He may call individually, like he did with most of the managers, and ask questions so that individually can get some, and then report back in an anonymous fashion so that you're free to talk as candidates like. That's helpful. We're still working on a couple of things as we're getting prepared for it.
Is the meeting gonna be here?
Yes. It'll be in the street yard here.
It's one of those two rooms. It's here though.
Yes.
I'll verify and resend that calendar invite out to everybody.
Well, you'll be 9 days into certified.
I'll have different colored hair.
Or none?
Anything is possible.
Maybe her flat.
Actually, I'm very fortunate, I have not been as involved at all in the center. It's really all the rest of the staff. They're really doing a dang good job. Very exciting. I think I might screw it up more than they want. So it's best that I'm not involved.
We all smile.
Yeah. Well, you know, there are things. We all have our different skills, right?
Any other questions? Do we have anything for you? Okay. So we'll take a 10-minute break or a 5-minute break and come back in executive session under ORS 192.660, bracket 2, bracket A personnel, bracket C medical staff, bracket E real estate, and bracket A legal.